The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everybody. Thank you so much for joining us for a webinar concerning question strategy and how to think about the breakdown of USMLE questions. Obviously, this is a really tough topic that we all must encounter at some point during our careers, and we have some great experts to talk strategy with you about it tonight. My name is Fred Bertino. I'm a final, I guess, PGY5 radiology resident in Atlanta, Georgia, heading to fellowship next year. And I've been working with MST for about 5 years and have tutored lots and lots of students from all over the country and all over the world for that matter. So I've been doing this quite a while. I'd like to introduce my co-hosts, Sana Majid and Sherry Smith. Sana, would you like to introduce yourself?
Sure. So thank you, Fred. My name is Sana. I am a recent graduate, just graduated from medical school. I'm completing my intern year in Boston, and then I will be going on to join Fred in the wonderful career of radiology.
It's an excellent choice. And we are also joined by Sherry Smith.
Hi guys, it's great to be here. I am joining you guys through TrueLearn. We are housed and based out of Charlotte, North Carolina. I am the Director of Academic Success there. I've been in medical education, so I've been with TrueLearn for 2 years, but I've been in medical education working with both faculty and students to study for licensure exams for going on 8 years now. So I'm super excited to be here and looking forward to a wonderful webinar.
We are really lucky to have TrueLearn involved in our webinar tonight. They were able to really power this session because they were able to lend us some of their awesome questions from their QBank that we, and by that I mean Sana and myself, can break down and hopefully walk you through our thought process. So we're really grateful for this partnership in giving this to you guys tonight. Moving a little bit forward with just some of the intro stuff. So we want to go through some general tips for USMLE style questions. Everything that we're going to be talking tonight is going to be very applicable to what you see on the exam and everything that you do in your practice. We want to talk about approaching different question types. Obviously, some of you who are studying now are going to know that there are lots of different ways to read these questions and also different types of questions that require a different part of your brain to work through that thought process. We are going to talk to you a little bit about what TrueLearn has to offer in terms of their USMLE Step 1 QBank, and we are going to tell you a little about what Med School Tutors does for your preparation in these exams. And that'll come a little bit toward the end. And then what I find to be maybe some of the more valuable time in our webinars is that we're going to do a live Q&A at the very end. So you guys can feel free to ask us whatever questions you might have on your mind, specifically maybe having to do with question strategy or working through some of these questions, or really just in terms of your preparation and what you should be doing, what resources you should be using. After the webinar, we will pass out a survey. You'll see it in the chat box that comes up, and our awesome people behind the scenes are working tirelessly to help answer even some more specific questions regarding TrueLearn and MST if you have more specific ones involving those programs. Please take a moment just to fill out our survey. It really helps us improve the quality of these webinars, and it'll get you guys more information as you go further in this medical journey that you're all taking. Definitely stick around for the live Q&A. I find this to be a really fun part for myself to help answer your guys' questions. I feel like, and Sana, you might agree with me here, I feel like we've probably been studying for Step 1 for like the past half decade. Like we took it once, but we've never stopped studying, like, 5 to 10 years after that. So I can't wait to pass it. It's going to be a really great experience. And then when we do go into the live Q&A, there is a way that you can do this through your GoToWebinar interface. On the side panel there, you're going to see a question tab that you can type your question in. It'll come to us in sort of an inbox. The questions that we think would be most applicable to everybody, we're going to answer out loud so everybody can sort of benefit from the answer. More specific questions are going to be more directed to you, and we can sort of type those back, and you can read those on a personal level if they're a little bit more on the private or specific side may not be so totally applicable, but we encourage you to ask. Try to keep it short and sweet. I think this is sort of like a Twitter thing where it limits how many characters you're able to send in one sentence. So keep it succinct, keep it direct, and we're happy to take you through our thought processes too. Sana, when it comes to, I guess, strategy and thinking about USMLE questions and moving forward with these. We all, as tutors, we go and we try to advocate for different general tips when it comes to thinking about these things. What kind of strategies do you recommend working for you and then working for the students that you've worked with in the past?
Yeah, absolutely. So in my experience, a lot of the difficulty with step 1 questions comes from second guessing yourself. You spend all this time studying, all this time focusing on all the nitty-gritty details, and a lot of it just comes down to presentation of the question. And it's their job to present it to you in ways that are foreign and new and trying to manipulate the information that you know, and it's sort of your job to see if you can use that information you have and sort of look at it in a new way. So if you think for sure that an answer is a certain thing when you're reading the prompt, don't get discouraged if you don't see those exact words in the answer choices. Oftentimes it'll be a second order, third order question that is talking about the same thing that you already know, but just pushing you a little bit further in your knowledge. So really trusting your preparation and making sure you take the time to read through every single piece of information they give you, because there will definitely be some red herrings, but the vast majority of the information they give you is trying to push you in one specific direction. And if there's something that really doesn't fit, trust yourself in sort of going through that whole process. What do you think, Fred?
No, I think that's really awesome. It's definitely a matter of trusting your instincts, realizing that a lot of the times these questions are really not out there to trick you. In fact, I usually tell all of my students that the USMLE Step 1 especially, and all the USMLE exams are really going to be the fairest multiple choice questions you ever take. There's really no such thing as a trick question on these tests. It's not really like anything you've ever taken before. Everything that you've seen on there, you've seen in your preparation, in other Q banks, in studying. It's remarkably fair. They might ask it in a slightly different way, but if you know how to put the material together and actually work through it logically, there's no reason why you shouldn't get a question wrong, except for maybe moments of weakness, of like personal loss of confidence, which we're all susceptible to. I mean, it happens to all of us. So, that's just human nature. But for the most part, you really should be very confident. To speak more on this, actually, Sherry, you've been in medical education for quite a long time and are actually really an expert at a lot of these thought strategies. What kind of advice, when speaking to students or in your experience, have you given to them to get them to be more confident in their test-taking skills?
Yeah, I love the advice that you guys are giving, and it's absolutely true. I think students, coming from undergrad, going through medical school, they are kind of focused in their thinking. Like, you're in anatomy, you're going to think about questions in anatomy, and you know how your faculty are writing these questions. And so these licensure exams, whether it's step 1 or step 2, they're not presented that way. It's bits of information that you guys are pulling together and integrating together to get the correct answer. I think my best advice for students that I've given is, we've always been told, or we've somehow, somewhere down the line, have thought, man, I'm a really bad test taker. Like, I'm just not good at multiple choice questions. Like, you're shaking your head because I know that you've heard that, you've believed that, or someone has told you that. And I really encourage individuals and students to just kind of step out and not have that fixed mindset, right? This is kind of a buzzword right now, but don't, obtain this growth mindset. Believe that you can do well. Go into studying and practicing and going into the exam. Believe that you can grow and become a great test taker, and don't get stuck in this belief that you're going to do poorly, because that will impact you greatly. But with any test you take to step 1 and step 2 and any other licensure exams that you guys have.
That's incredibly insightful, because I think sometimes we forget as medical students and then as residents that we constantly remind ourselves, oh my gosh, we are terrible at taking standardized tests. Oh, I hate it. You've made it this far in your medical careers. You're about to take step 1. You've made it through the first 2 years of medical school, taking exams very similar in many cases to the USMLE. At this point, I'm not quite sure that reasoning is really valid anymore. I think you've all sort of proven that you're excellent test takers to even arrive to this point. So realize that, looking at the bigger picture of things, take that mindset out of yourself, realize that you do have all the tools to do extremely well on this exam, and that, tens and thousands of physicians before you have also aced this test. There's no reason why you guys can't do this too. Okay. I know we sort of gotten into a really good discussion. I thank you guys for doing it. That was really awesome, actually. You know, just to reiterate some of the strategies that Sana and I are going to be focusing as we go through some of these questions, is to remember to trust your instincts, as Sana was saying, ruling out incorrect answers for the right reasons, and remembering that zebras may not be correct. We're going to touch on this as we go through our thought processes through the multiple choice questions, so you can see this happening in real time. Remember the wordings of the questions and make sure that you're answering the question that is actually being asked. This is incredibly important because this is usually the root of why students may get questions wrong. It's usually comes down to just understanding what they're talking about. Never guess. There's always the answer in front of you, whether you can recognize it immediately or maybe after a little while. And you know, if you find that you're leaning toward making a guess, make it as educated as possible. And I'll refer back to our first strategy here of trusting your instincts. So if your gut is trying to tell you something and you're not quite sure why, sometimes the stomach is a lot smarter than the brain when it comes down to the actual test taking. So always go with that gut instinct. Diagnose the patient before you start answering the question or looking at the answer choices. As you study, and this is probably even more important for your study habits as you're preparing for the test, you really want to try practicing for this exam as if it were a fill-in-the-blank test rather than if it were a multiple choice test. Because I can promise you that if you practice recall rather than recognition, you are preparing for a harder exam and then will be pleasantly surprised when you encounter the multiple choice question where you can actually see the answer in front of you. So practice harder in the effort to make the exam easier when you sit down and take it. And then don't rule out an answer choice just because it doesn't fit a classic presentation. Variations are common, and remember, not every patient reads the textbook, right? So, you know, patients will present in lots of different ways, maybe slight variations. If 9 out of 10 of the things that you're telling you is pointing to gout, for example, and the 10th out of 10 thing is not quite pointing to gout, it's still probably gout. So don't lose your focus just because something isn't quite adding up. As Sana was saying before, every once in a while you might get a red herring somewhere, but remember that, you know, if all signs point north, or if it sounds like a duck and walks like a duck and quacks like a duck, it's probably still a duck. Okay? That said, we're going to go ahead and dive in. I'm going to transition things over to Sherry, who is going to share her screen here and show us the TrueLearn interface as we dive into this.
That's right. All right. Are you able to see that dashboard? Just checking in.
Yep, I am able to see the dashboard. It looks really good.
All right, so let me go ahead and just zoom in so we all see the questions once I start. Go ahead and start this. Looking good?
I think mine might still be loading.
Yeah, I'm still seeing the dashboard.
You're still seeing the dashboard. Okay. It's loaded on my side.
There we go.
I can see it now.
For some reason it was paused.
Interesting.
Would it be a webinar without technical difficulty? All right. No, we're rocking and rolling. So we're going to start off. It says question 5, but we're going to start off here, and I believe Fred is going to take this one.
Sure, yeah. So I'm going to walk through how I would approach STEP questions. You know, feel free to take notes on my thought process. If something I do kind of resonates with you, maybe write that down. If something that I do you disagree with, you know, either don't follow the advice or feel free to ask me about it later in the Q&A and why I do something. Usually what I'm doing is somewhat evidence-based, more experience-based, because I've done this before. So hear me out and see if you like how I go through it. When I look at a question like this, I see a lot of words, I see answer choices as I would expect to see, and I already know that the majority of the question is probably going to point me in a specific direction. So everything inside this question is going to be something I need to know to answer the question correct. The second I start asking myself, what if something, or suppose this, or they didn't mention this, I'm already hypothesizing to get the question wrong. Okay, everything you need to know is going to be inside of this question stem, and that is true of every single item on the exam. So I'm going to jump in. What I like to do is I like to look at the question itself first. So I will jump to the end of the question, and I'm going to read it out loud. Which of the following is the most likely cause of the patient's murmur? So I already know that this is going to be a several-step question. We're going to be talking about a patient's murmur in this. Now I need to figure out what kind of murmur maybe it is, or potentially what the etiology of it is. So going from the beginning, a 12-year-old boy, oh, that's a lot of highlighting, but that's okay. I'm a highlighter by trade, so I like to, I think I read better in color. If you look at any of my textbooks in radiology, like they're all like yellow. Highlighted, so.
I'm going to change, and don't be worried, I'm going to change the interface just because, just
Easier
Sure.
to unhighlight.
easier, yeah. Okay.
Looks great.
So a 12-year-old boy, yeah, we can start by highlighting the question. Actually, it's probably a good start. Most likely cause the patient's murmur. Perfect. So a 12-year-old boy, and I'm going to pause right there, and I'm just going to highlight that epidemiological fact. I know that epidemiology, how old these people are, the gender of the patient, these things are very important diagnostically when trying to figure out the diagnosis. So I already know that a 12-year-old boy is going to be very important to me. We're talking about a pediatrics case, okay? When I think about pediatric cases, I'm thinking about, okay, if we're talking about a heart murmur in a pediatric patient, is this a congenital heart defect? Is something here going to lead me down that road? So I've already begun to think in terms of my filing cabinet of where in my resources I need to pull that information. Brought in by his parents for evaluation of developmental delay. I'm going to highlight developmental delay because I think that that's very important to understanding the concept here. The history is remarkable for gross motor and speech delay, and he has received physical and speech therapy since childhood. So again, this is going back to developmental delay problems. You could highlight the specifics, but I know that he has a developmental delay. His mother notes that he is impulsive and inattentive, okay? This suggests another symptom here. I'm going to highlight impulsive and inattentive, and I'm going to go back and try to interpret it a little bit later. It's okay. When I'm doing different Q banks and things like this, I tend to highlight and everything kind of goes crazy. I've been in this situation before. If it's, we can just highlight specific words, because as you guys get better at this, it might not be worth your time to highlight entire sentences and stuff. By the time I was finishing my Q banks, as I was getting toward the end of my studying, I was just highlighting specific words or specific numbers, keeping things super succinct for myself. That, that'll save you some time in the actual exam. And remember that on the test, you will have the ability to highlight on the exam. So just to recap, so we can get back. 12-year-old boy, developmental delay with evidence of that, impulse and inattentiveness, and these have affected his performance in school. When I'm thinking impulsiveness and inattentiveness with effect of performance of school, I'm thinking that that's basically a buzzword for ADHD. On physical examination, he has a long and narrow face. That's extremely important because now we're getting into some of the specifics. Large ears, also very important. Prominent chin and enlargement of the testes, okay? Having studied this for so long, these are all buzzwords for a specific diagnosis that I know, and many of you might on the other side of here know this as well. I'm also noting in the next sentence, hyperlaxity in the joints, specifically finger and thumb, but all I needed to see is hyperlaxity and joints, and I'm set. Okay, and now they're saying that cardiac auscultation reveals the presence of a murmur. Which of the following is the most likely cause? Okay, so now I'm given some pause. I realize that they're asking me what kind of murmur this child has because that's what I started my question off with. And I understand that I need to come to a diagnosis to go to the next step in the question to figure out what kind of murmur. Hearing that this young boy having a developmental delay, again, male patient, developmental delay with ADHD with these facial features points me in the direction of a diagnosis of Fragile X syndrome. The buzzwords for Fragile X are going to be long, narrow face, large ears, prominent chin, and enlargement of the testes. You have to know how that disease presents in order to get a question like this right. In many of your resources, your Q banks, any books that you're using to study, all of them are going to focus on this as a very high yield fact. I know that this is Fragile X especially, and it's confirmed by the fact that my patient is male. That also helps because you know that it's an X-linked disorder that's generally going to affect males. The hyperlaxity of the joints is also associated with this. But now I'm given a little bit of pause in my thinking because cardiac auscultation reveals a murmur, and maybe I forgot what kind of murmur Fragile X is associated with. So now I'm panicking a little bit on the exam. Don't panic, don't panic. We just have to reverse our thought process by looking at the answer choices now. Looking at answer choice A, I see atrial septal defect. In my knowledge bank, what do I know ASDs to be associated with? The number one thing you want to do with that is associate ASD with trisomy 21, okay? Because that's going to be the fact that I need to know for STEP, I can eliminate an atrial septal defect from my differential, okay? Mitral valve prolapse, lots of different things could be associated with mitral valve prolapse. It could be maybe a long-term effect of, say, some collagen vascular diseases or cystic necrosis of the mitral valve or degeneration of the mitral valve. Various things could do that. I'm going to come back to that because I'm not quite sure where that's fitting in. A patent ductus arteriosus. PDA is frequently associated with lots of congenital heart defects, especially the cyanotic ones, because there has to be some sort of a connection between the arterial and the venous side to keep these kids alive. Given the fact that this kid is 12 years old, has made it past the cyanotic history, has not necessarily needed anything here to continue on life support for something, I'm not going to interject any more information into this. I'm going to eliminate PDA from my answer choices here. Mitral valve stenosis is the next on my list here. I know to associate mitral valve stenosis with rheumatic fever. This is something, or rheumatic heart disease, I should say more specifically. This is going to be your strep infections. I'm not getting a vignette here for strep infections or a history of this kid with strep pharyngitis. So I'm going to eliminate that. It's not going to be considered in my differential. And finally, aortic stenosis at the very end. I think of aortic stenosis in terms of different age groups, right? If I'm thinking about a young person with it, first of all, the most common for aortic stenosis, I'm thinking about old people with syncope. If you hear about a 70-year-old guy who falls out, has a syncopal episode, you want to think about aortic stenosis murmur in that person. If you're thinking about aortic stenosis in a middle-aged person, say 40 to maybe 50 years old, now you want to think about maybe a bicuspid aortic valve, which is actually like the most common cardiac defect in general. And then if we're thinking about aortic stenosis in young people, we're thinking maybe is it associated with a coarctation, which might be found in Turner syndrome, which also has a higher association with a bicuspid aortic valve, which could lead to later onset aortic stenosis. Or you want to think about maybe supravalvular, like in kids with Williams syndrome or something like that in those instances. Not once did the term Fragile X come into my mind when I was thinking about aortic stenosis at all, so I'm going to eliminate that because that's not part of my filing cabinet of information. The only answer choice that I have left is mitral valve prolapse. I had a really good reason to eliminate all the other answer choices, even though I didn't quite know the association of Fragile X with mitral valve prolapse, and I'm going to choose B as my answer choice in this case. Sweet. That would have been really embarrassing.
Nice.
Okay, so the nice thing about QBanks and TrueLearn specifically is that it's going to give you a lot of explanation for exactly the high yield points that you need to know. It's going to give you a little bit of insight into the diagnosis, and it's going to give you the answer choices at the bottom and tell you why you got the one answer choice correct and then why the other ones are wrong, sort of like how I did in my mind. When you get to the end of your study period, you really want to try to get your mind in the idea that I'm going to treat my brain as a QBank. I need to give myself reason as to why other answer choices are incorrect and why the answer choice I picked is correct. The best students who score the best on this exam are capable of asking themselves the question, what would have to change in the question stem for any of the answer choices to be a correct answer? And those are the students who are taking one question and really turning it into 5 different opportunities for knowledge acquisition in this process. Specifically, parts of the TrueLearn QBank that I really like are that it's going to give you the bottom line, which is essentially like an educational objective, and it's going to tell you the high yield fact that you need to know and associate with these topics that they're asking. And then a little bit, excuse me, into the insight, it's going to expand a little bit on those teaching objectives and remind you to go back to your sources and say, okay, what is it about these things that I need to know inside and out, so you can go back and reference your sources later. Sherry, is there anything to add in terms of what, how I got through this, or at least my thought process from an education standpoint?
No, I think that's completely right. It's one question, but it can turn into 5 questions because you're going to review, a lot of concepts to figure out why it's correct and why it's incorrect. A big question that I get from students is, I'm reviewing these answers and I'm spending just way too much time reviewing them. And I remind students, depending on where they are in their study, is that going through like a Q bank, any Q bank, when they're going through it, it is essentially a time for them to know, I guess, get a sense of what they know and what they don't know. And it's a little less than just teaching yourself. It's not learning, but you're learning about what you know and what you don't know. And so if you're finding that you're spending an hour or 2 each question because you're writing everything down and everything, you really need to refocus and figure out, okay, I'm testing myself. I know I don't know this. I'm going to go back and review it. I do know this. I'm going to go back and review it. But this is the time for you to learn that.
Absolutely.
Awesome. Sana, how did I do?
You did great. I think the one point that you made is something that I really try to emphasize to all my students who are studying, is every time you're studying about a disease, because when you're studying from first aid, it's all organized by disease and not organized by symptoms. And that's how the patients present, right? They don't present with a disease, they present with a constellation of symptoms. And every time you study a disease, I want you to take a step back and say, okay, if I was writing this question, how would I write it? How would this patient walk into my clinic? What would the presenting symptoms be? What would I write? And what would the second order thing be? So the symptoms are this, and then here's this biochemical pathway that this disease operates through. So really thinking about knowing how every single disease presents, I think, is the most surefire way to get that first step. And then that second step about the murmur, that comes with just repetition and studying. But I think that first step in identifying the disease is really the critical part that you can do while you're studying from first aid.
Awesome. Awesome. Cool. Thanks, guys. Let's move on to the next question. Okay, I think.
Pretty sure this is Fred's again, or we can go back and forth if you want me to go to the next question.
Well, how about let's have Sana take a question.
Yeah, we can do that. Let's go to number 2.
All right, this is me. Okay. So I approach questions a little bit differently from Fred. I actually like to just start from the beginning, mostly because I'm too impatient and I want to just get into the question. So for me, 59-year-old man comes into the physician's office complaining of shortness of breath and cough. Okay, so we have a middle-aged to elderly man, not really elderly, middle-aged. We'll stick with middle-aged.
They say old is your age plus 20. So that's what.
Yeah, 50 is the new 40.
Exactly.
So 59-year-old man coming into the PCP's office, shortness of breath and cough. So I have an idea that this is maybe a pulmonary process going on, but certainly can't rule out any cardiac process and anything else that can affect the lungs. So maybe lungs, maybe something else. Not a whole lot of information from that line, but starting to get thinking about that. History of diabetes and hypertension, okay. He is status post 3-vessel CABG. So this is really important information, right? He had a procedure done just 5 months ago, and this is a critical piece of information. So this is going to change sort of the context through which I view this patient. So he just had a heart attack. He had 3-vessel CABG. What medications is he on? What things have changed in his life in the past 5 months? Because they're telling you this information for a reason. Like Fred said, almost every piece of information they give you is given to you with a specific intent. They're making these patients up, right? They're not going to have random pieces of history that aren't relevant. Almost everything in these patients will be relevant. So 3-vessel CABG 5 months ago. And he was given atenolol and amiodarone post-operatively to control his arrhythmia. So like I said, the first question that popped into my head was, what procedure was done? The CABG. What medications is he on now? Because that's a big change, right? So something for me to tuck away for later, and we'll talk a little bit more about atenolol and amiodarone once we start to keep thinking. 10-pack-year history and quit smoking 4 years ago. So he was a smoker. So all of this is pointing me towards lung disease, right? 10 pack year history, quit smoking 4 years ago. It is certainly a smoking history, but it's also not a terrible smoking history. He's not an 80 pack year smoking history guy, not a classic COPD presentation. So maybe a little bit lower on my differential, but certainly something to have on there, COPD, sort of those sort of diagnoses. Diabetes is well controlled with metformin and sulfonylureas. Okay, so other medications he's on, good to know, tuck that away for later. Lung examination shows fine bibasilar crackles on auscultation with equal lung expansion. Okay, so we're hearing crackles on auscultation, right? So crackles, always lung pathology for sure. I'm almost 100% confident that this is some sort of lung disease. And now we know he has crackles, so we can think about what crackles mean as opposed to some of the other noises that you can hear on auscultation. Cardiac exam, mid-sternal scar, makes sense, he just had a cabbage. And grade 2 out of 6 systolic murmur in the upper sternal border. So, brief interlude into murmurs, 2 out of 6 systolic murmur. So systolic murmurs can be either way. Diastolic murmurs, always bad. Systolic murmurs can be innocuous, can be bad. Upper sternal border. So he's a 59-year-old guy, upper sternal border murmur. That's making me think of AS. So it could be just run-of-the-mill AS. It could be something else, but we don't have a ton of information from that. So we'll just let that sit for a second. Temperature is 37.5, fine. Pulse is 90, fine. Blood pressure is fine. So vitals, not really getting any information from that. Chest x-ray. So of course, chest x-ray. So chest x-ray shows multiple peripheral areas of dense airspace opacity. Okay, so now we have some actual pathology to work with, right? So we're seeing dense airspace opacity, and we can talk about what that means and what that means in like not radiologist language, but that certainly suggests, again, we're having airspace disease and we have actual pathology in the lungs itself. So then of course, what is the most likely cause? So we're lucky in that this is pretty much a first order question. And so what I mean when I say first order question is there are questions that are asking you basically what's the diagnosis. They give you a patient that walks in, they give you all these symptoms, and they're saying, okay, what's going on here? And so this is a first order question. What Fred had earlier was more of a second order question. He figured out it was Fragile X, and then it's like, okay, but what murmur is associated with Fragile X? It takes it another step. So step one is a lot of both, so you have to be prepared to sort of navigate in both of those territories. So based on what I have so far, I'm thinking about all of the different causes of lung pathology, right? So there are a bunch of different things it could be, but the biggest things that stuck out to me from this history that are unusual is the fact that he had a surgery 5 months ago and he was recently started on medications. He said all of these symptoms are sort of new for him. He's coming into the PCP's office, and the only thing that's new in his history is that he had this cabbage. So something to keep in mind. So then, if I'm still sort of toying with what the actual diagnosis would be, I can look through the options. So the first thing we have is amiodarone toxicity. And so amiodarone, as many people, as was discussed earlier, a lot of you might already be thinking about amiodarone toxicity, because amiodarone's a drug with one of the most significant side effects that is known is lung parenchymal disease and restrictive lung disease that comes as a consequence of amiodarone. So that is definitely an option, and that's one that's pretty high on my list, given the fact that he had a cabbage 5 months ago and was just started on this medication. So maybe amiodarone toxicity, I know that that's a side effect of amiodarone. Other side effects of amiodarone that are very common are thyroid disease, and sometimes you can have visual abnormality, sometimes you can have lung problem, or excuse me, not lung, I already said that, liver disease as well, but the lung sort of disease is one of the most common and well associated with amiodarone. So that's an option. Atenolol toxicity. So atenolol is a beta blocker. So as you can sort of think about what would a beta blocker toxicity look like. So beta blocker toxicity is very different than any sort of the lung toxicities that we talked about, right? So beta blockers, the main purpose of them is to slow down your heart, right? So you can imagine if you got too much, the biggest side effect that you would see is bradycardia, and then beta blockers have some effect on blood pressure as well, so hypotension. This patient's vitals have been good, and I don't really know about anything with beta blockers in lungs, so I'm a little less concerned about it. idiopathic fibrosis, option C. So idiopathic pulmonary fibrosis is a disease that can happen in elderly people. So I'm thinking about what I know about this disease. Restrictive lung disease sort of happens in elderly adults. But my thought is that this would be more of a chronic issue. This would be something that would be going on for many, many months. And I know it's a restrictive lung disease, so I would expect to see some FVC, FEV changes as well. Not that they gave me any of that information. But the biggest thing that's driving me away from that is this guy's relatively young, and he also has no sort of chronic history of this going on for many, many years or many, many months even. This is all sort of new. So I'm a little less concerned about that. Next option on the list is metformin. So metformin is used in diabetes, right? So we've discussed that his diabetes is controlled with metformin and sulfonylureas. And so you can imagine a diabetes medication like metformin, even if you're not 100% sure the specific mechanism of metformin, you know it's a diabetes medication, so it's probably involved in lowering your blood sugar. And so excess metformin toxicity will lead to hypoglycemia. And so you think about what are the classic symptoms of hypoglycemia, and it's more palpitations, confusion, a little bit more acutely sick looking. Nothing that I know about the lungs, right? Nothing specific to the lungs itself, so I'm not worried about that. Non-caseating granulomas is my next option. So non-caseating granulomas, when you see those words together, I don't want you to think anymore. I want you to go straight to sarcoid. And so every single time you see non-caseating, and so non-caseating means you don't have that central area of necrosis, right? And so that always means sarcoid. And the classic thing that I know about sarcoid is the hilar adenopathy, right? And you see that on chest x-ray. You don't see this dense airspace opacity. It's the hilar adenopathy that you see. And this person also just doesn't really fit the description. Not to say that anyone can't get sarcoid, but the classic presentation that you're going to see on these step 1 questions is going to be a middle-aged African-American female. That is just almost always what they will present you with, because that's just the most common population. So again, not super high on my differential, doesn't really fit, not super chronic presentation as well. And then option F, so permanent enlargement of air spaces. And so this is sort of what I was talking about before in terms of them wording things not quite how you think. So permanent enlargement of air spaces, to me, that just translates to emphysema. So they're just using a different wording. And so emphysema, like we said, falls under the bucket of COPD. And this patient has a 10-year history, but he quit 4 years ago, and his symptoms are kind of new, and he's 59. COPD sort of is like a chronic course that presents over a long time in people who have been smoking for ages and ages. And in terms of his actual lung expansion and his chest x-ray, it's just not fitting the picture of an emphysema patient. An emphysema patient, you expect sort of that barrel chest and that hyperinflated lungs, and none of that seems to fit with this patient. So based on everything that we've gone through, and based on sort of the key factors that I pointed out, which is the chronicity in this case, sort of how young this patient is, and all the other options just not really fitting to do with lung pathology, that sort of points me in the direction of amiodarone toxicity.
Nice.
Thanks. So like we said, but what's great about TrueLearn is you have all of the correct answers. So you have a nice explanation for the correct answer to sort of point you towards the key factors in the history that should have been pushing you. So you can really identify those key points. And then also in the wrong answers, it tells you, well, what does atenolol toxicity actually look like? What does IPF actually look like? And sort of go through those things so you could actually learn, test yourself, absolutely, but also take it as a learning experience to learn more about the diseases that you maybe didn't know so much about.
That's awesome, Sana. I loved how you really didn't sway at all from the clinical vignette. You always brought it back to the history, to the demographic of the patient. You brought it back to exactly what the physical exam and the medication history findings were telling you, and you didn't let any other sort of outside information get into your mind. I know that you said that you had a history of diabetes, but like you never for a minute even entertained the idea of metformin toxicity, because They didn't tell you that he was taking any, well, he is on metformin and sulfonylureas, but it's controlled and doesn't seem like this is the right patient for something like that.
Yep.
Probably knowing what the toxicity syndromes of drug overdoses of various types is going to be incredibly important for questions like this, which are covered in toxicology chapters of first aid and things like that as you go through this. But I thought that was really awesome.
Thanks.
Can I add something just about the questions?
Absolutely.
Please. So after you answer our questions, and I think this is very common in other Q banks as well, is that you'll see a breakdown of percentages on the left-hand side. So A was 70.9%, B is 2.4, and so this actually represents how many people who are using the bank, what were their choices. And so A is the correct answer. The majority of students chose A, but you can also see some distractors. So they actually, some of them C, 10% chose C, 9.8% chose F. And so you can start to see with, especially more difficult questions, what are ones that are the maybes, right? That other students are struggling with, and that's a good thing to note. Another thing, if you don't know, is that USMLE is different in a lot of ways, and other board exams is that the number of answer choices that you have will vary from question to question. So the last one, I think we had 5 answer choices or maybe 4 answer choices. It was easier to figure out, okay, I'm going to rule out 3 and number 4 will be right. But you can have up to 11 answer choices. And so there's a lot more to think about, a lot more that you have to kind of just, adapt to and figure out and rule out. And so you got to prepare for that.
Definitely. I'd like also just to add a little bit about radiology on the exam, because sometimes this can be an area of anxiety for a lot of people. Remember that when you go into step 1, this is not an imaging test. You are not going to be expected to really know anything about radiology. You might be expected to know the buzzwords of certain chest x-ray findings, so like dense airspace opacities, what that should indicate for you. An airspace opacity limited to a lobe is a classic for a pneumonia, for example. Fine reticular patterns at lung bases, you're thinking more pulmonary fibrosis. Increased lucency with widening of the ribs and increased chest volumes, you're thinking more of an emphysema type of situation. Hilar adenopathy, sarcoidosis. If they ever show you a chest radiograph on the exam, chances are the image quality is going to be pretty bad. You're never going to be asked to make any real specific diagnosis, number 1, and the findings should be obvious. And by obvious, I mean the heart's probably going to be on the wrong side, or the lungs are going to be totally white and you're not going to be able to see through them. And if the heart's on the other side, you want to think situs inversus or Cartaginer syndrome or something. And if the lungs are totally white, you're thinking, okay, bad lung disease, and that's about it. That's all that you really got to put together on this thing. It's never going to go more than that. What I can tell you, though, is that imaging can sometimes be asked in the exam for anatomical questions. So you might want to be familiar with some normal anatomy as they might present on a CT scan or something like that, knowing that where the liver is relative to the spleen, relative to the kidneys, knowing maybe what lumbar levels certain vessels of the aorta might originate from. And all of these are going to be in the sources that you study. So I don't want you to freak out on that. So that was just
I'd like to really second that, and also say that applies for histology as well. I think in general, what I've also found, and what a lot of my students tell me after they take the test, even when they're taking practice tests, is histology and radiology is almost always a supplement in these questions. Even if you have no idea what you're looking at, and most of the time you'll be able to tell. Most of the time it'll be something obvious, as Fred was saying. But even, let's say you don't know. Let's say you have no idea what you're looking at in terms of the path or the radiology. It is almost always supplementary 90% of the time, and you can get the question you write without that information. It's additional to sort of help you cinch it, but not necessary.
awesome. Totally agree. All right, let's jump forward. Okay, so again, you guys sort of know my thought process. I'm going to start by going to the bottom of the question. I want to see exactly what I'm looking for specifically in this. So if we could scroll down just a little bit. What is the underlying cause of the patient's presentation? Awesome. Okay, so not a lot of information there. Nothing really to focus my thought process as we go forward, but you're going to have questions like this. What do I want to think about now? I want to think about what is my diagnosis for this patient, and then what are the associations that I need to make in my head based on that without even reading it. So I'm going to begin now. So 47-year-old homeless man, must highlight it. That's like already we're beginning with important information. Brought to the emergency room by police after being found unconscious. Okay, so he's homeless and he's unconscious. So this is already a pretty bad situation. On arrival, he's awake, but he's altered and unable to provide a coherent medical history. Okay, so again, altered, unconscious history, middle-aged person, homeless history. Fine. Past medical history shows intravenous drug use and alcoholism. Must highlight that. That's incredibly important for my rationale for the question. Temperature of 101 Fahrenheit. Definitely highlight that. That's a fever. Side note on numbers for the exam. When you go in, and I'm going to touch on this too with the lab values, you want to go in with an understanding of what should be normal values, and you're going to want to have normal values for a few things memorized before you go into the test. There is a lab tab, and TrueLearn actually has one in the upper right-hand corner of their screen there that I'm sure gives you a catalog of the labs and things like that for various things. I'm not saying you got to memorize everything on this. I still don't necessarily remember TSHs or PTH levels or something. Like, I'm not going to necessarily remember those things. But what's going to be the most common thing they ask you about? Definitely want to have a knowledge of a normal temperature, right? 37 Celsius, 98.6 Fahrenheit. Anything over 100.4 is a fever, so that's something to remember. A blood pressure, 120 over 80 is perfectly fine to remember as normal. But the second I start seeing a systolic blood pressure less than 100, that's hypotension to me, okay? A pulse, if I'm over 100, I'm thinking tachycardia. If I'm lower than 60, I'm thinking bradycardia. And then respirations, 24, probably appropriate. I'm okay with it, with a number of like 24. Anywhere from 16 to 24 is probably normal. If you're in the single digits of respirations, or if you're in like over 30 for respirations, now you're starting to think bradypnea versus tachypnea, respectively. Need to remember my words there. I haven't actually thought about bradypnea since being a radiology resident. But okay, so I'm noticing that he has a fever. His blood pressure looks fine to me. Okay, I'm okay with a middle-aged person having a 140 over 95 millimeters of mercury blood pressure here. If we're over, if we're sort of like in the 170s to 200 ranges systolic, that's going to be the USMLE telling you that he's hypertensive. Pulse of 78 within my range of normal. Respirations 24, maybe slightly elevated upper limits of normal, but I'm basically okay with that. I'm not super concerned. This person has erythematous macules and pruritic papules on his buttocks and lower extremities. I'm going to highlight that. That's a rash. This test loves dermatology and loves rashes because it can be linked to so many different pathologies, multi-system, multi-organ system things. So that's very important to me. MSK examination reveals pain in joints. So I'm just going to think, okay, he's got pain in joints. Big pictures here. We got to, because this is obviously multi-systemic now, okay? We're bringing skin into the play. We're bringing joints into play. This is derm. This is rheumatological. This is multi-system, okay? On passive, okay, fine. And then he has hepatosplenomegaly on an abdominal examination. So I want to highlight hepatosplenomegaly. Again, multi-system process here, okay? Now we finally go into some labs. Kind of a confusing picture. Alcoholism, IV drug use, weird rash, joint pain, hepatosplenomegaly. Let's look at my labs. Again, you want to have a good idea of normals for especially these labs that we have here. A white blood cell count, 9,500. To me, anything over 10 is probably going to tell you that there's a white count going on. 13 for sure, okay? 9,500, to me, that's in my range of normal, so I'm okay with that. Hemoglobin of 11.8, again, once you start getting into the single digits, they're trying to tell you that there's a bleed somewhere, okay? Or they're super anemic. 11.8, maybe borderline anemia for a guy, probably should be a little bit higher. But looking at his hematocrit, I'm noticing that that's probably okay for where he is. Not really going to change my differential all that much. Even if you can't remember the specific numbers that you want to, this is okay from what I'm considering. Maybe slightly anemic is not going to contribute to anything because I know that he has some sort of inflammatory process going on. Platelets 150,000. To me, that's my limit of normal. Anything below 100,000, now I'm thinking thrombocytopenia. Anything over, say, 500,000, now I'm thinking thrombophilia or something like that. Okay, normal to me. AST, ALT. If you're in the hundreds, it's abnormal. Okay? These numbers should be low. I'm thinking low double digits, like maybe somewhere, and single digits. So anywhere between, say, like 1 to 2 to maybe up to your 20s, probably going to be somewhat normal. Certainly below 100 can be in the normal range too. Double digits, you're in a safe bet. The second you start getting into triple digits, into your hundreds, now you're thinking to yourself, okay, this is probably some sort of an acute inflammatory liver process, because AST and ALT, misnomer, they're not liver function tests, they're liver damage tests, okay? When hepatocytes break open, they release these enzymes into the bloodstream, and that's why we can detect them. So AST, ALT, not liver function, they are liver damage tests, and there's clearly liver damage happening here. Alkaline phosphatase, nonspecific. I don't necessarily have a great number to remember for this one, but if they're telling it to me and it's probably in the double digits, I'm going to go with the fact that it's elevated. I can always refer to my lab tab to make sure that I know what the normal could be here, but I've done enough questions to sort of feel uncomfortable with that number. ALK-Phos, my mind goes to biliary system and it goes to bone. Those are the two main things that I'm thinking of with an ALK-Phos. Given that there's some sort of a hepatitis going on here because of an elevated liver damage finding, I'm going to go with biliary on this one. Next thing down, I notice my total bilirubin is elevated at 1.5. I like a total bilirubin of 1 to be my upper limit of normal. If you combine the indirect and the direct and it's less than 1, you're in a good position. Anything over than 1, you're starting to think that. And if a patient is jaundiced, they definitely have hyperbilirubinemia. So that's your answer there. I notice that the HIV test is negative. I notice that the anti-hepatitis C virus antibody is positive. And I notice that my complement is decreased. Now, what is the major underlying cause of the patient's presentation? I'm going to hold off before I go to the answer choices and try to put something together here. There's a hepatitis going on with some sort of decrease in this patient's complement, okay, as evidenced by the lab findings, but also by the hepatosplenomegaly. And now I'm noticing that he has this weird rash combined with joint pain. So I'm thinking rash plus joint pain, there's something rheumatologic going on. His complement is decreased. I've confirmed that something rheumatologic is going on, combined with a liver pathology. Okay, I'm okay with this. Let's go take a look at the answer choices to see what's going on.
I want to preface that there's something wrong. The right answer is already shown to you. So I'm going to move down, but we can still talk through it if that's okay.
Of course, yeah, no problem.
All right.
Of course, immune complex deposition. That was totally what I was 100%. So I'll come to that one last and explain my reason.
Okay, perfect.
So let's start from the bottom and go up. Granulomatous inflammation of the biliary ducts. When I think granulomatous inflammation of the biliary ducts, I'm thinking about a primary bile duct pathology. I'm thinking about things like primary biliary cirrhosis. I'm thinking about maybe primary sclerosing cholangitis. Primary biliary cirrhosis, I'm thinking about people with antimitochondrial antibodies. These tend to be in female patients, maybe middle-aged, a little bit older, and this can lead to early onset liver failure and PBC, primary biliary cirrhosis. It's a cirrhotic problem. I would expect to see cirrhotic changes in this patient. I would expect to see more jaundice, not necessarily telling me that that was what was in the vignette despite the hyperbilirubinemia. So therefore, I'm not going to pretend this patient is jaundiced. So not jaundiced patient. And in a cirrhotic liver, the liver shrinks. It becomes nodular and it gets smaller. This person had a huge liver, okay? Probably not going to be cirrhosis. So I'm going to eliminate answer choice E. Opportunistic infections. Opportunistic infections happen in immune-compromised people. When I think about opportunistic infections, you want to associate immune-compromised state, and with that, usually in the setting of USMLE question, they're leading you in the direction of HIV. This person's HIV test was negative, so I'm not going to entertain processes that could affect the liver. Other things that could suggest an immune-compromised state. You want to think about patients without a spleen, because that's going to make them more susceptible to encapsulated bacteria. Those are your Shin bacteria, right? So your S, your Streps, your H flu, and your N, your Neisseria. Those are the big three to remember for there. And if they tell you that the patient is a cancer patient and receiving chemotherapy or something like that. Those are also going to be buzzwords for immune-compromised states. That and HIV. Immune-compromised state people wind up getting infections to their liver like Candida microabscesses. That might be even a fact specifically with the liver beyond the scope for step 1. So I don't even want you to think about something like that. But you want to remember that people can get funginias, bad pneumonias with immune-compromised states. We're not really seeing that in this patient here. We're seeing more of a liver and a rheumatologic problem. So I'm not thinking infectious. If I were to go in the direction of HIV, Kaposi sarcoma can really show up anywhere. And this is one of those times where if you're ever thinking about Kaposi sarcoma, you think about it on the skin, mucosal surfaces. Remember that the intestines are also mucosal surfaces as well. So if they ever show you a colonoscopy finding with what looks like Kaposi sarcoma in an HIV patient, you can pick that answer. It can show up there. So just realize it. Sometimes you might get a red herring, but it could just be a variant of something they want to test you on. Moving forward, not thinking it's an opportunistic infection. Portal hypertension. So again, in portal hypertension, I'm thinking that there has to be some sort of a cirrhotic pathology going on here. That's the first and foremost thing. You can have portal hypertension secondary to something like a hepatic vein problem, like Budd-Chiari syndrome, hepatic vein thrombosis, or severe right heart failure that congests the liver so much that it actually increases portal pressures. Those are way less common, and it's not worth the USMLE's time to test you on things that are less common. So when you see portal hypertension, you want to go to cirrhosis first. Does this person have cirrhosis? No. They didn't tell me that they were jaundiced. They didn't tell me that they had any sort of variceal bleeding. They didn't tell me that they had any presenting varices like Kappa-Medusa or esophageal issue, gastroesophageal varices. There was no ascites mentioned. There was nothing else there to suggest that there was portal hypertension. They did mention he was alcoholic, but that was the only clue that I had here. Not enough for me to go with this, okay? They did mention that he had splenomegaly, which you can see in portal hypertension, but they said the liver was big too. And again, in cirrhotic patients, the liver's got to be small. Decreased metabolism of estrogen. This is also going to be seen in cirrhotic patients, okay? You lose your ability to metabolize the estrogen, and if there was a decreased metabolism of estrogen, the biochemical findings of that would be a hyperestrogenergic state. So gynecomastia in a male, telangiectasias on the skin from dilated blood vessels, decreased libido, things like that, especially in male patients. So again, not seeing any of those syndromic findings with this, I'm going to eliminate it. I finally get to A, which is immune complex deposition, leading me in the direction of this is a patient with a rheumatologic problem, rash plus joint pain, and they have hepatosplenomegaly with a positive antibody for hepatitis C. This tells me that this is probably something in the realm of an hepatitis C associated autoimmune process. The thing that comes to mind here is going to be like a mixed cryoglobulinemia, which would lead to these findings. And I know that, again, taking this to the next step in your room chapter, that an immune complex deposition is going to be a type 3 hypersensitivity reaction, of which cryoglobulins fall under in that situation. So that's why A would be the right answer here. Nice. Again, going through the answer choices here, I'm not going to sort of go ad nauseum here. Everything basically I said is going to be listed here in some way, shape, or form, maybe with slight variation, but it's going to get you on the right track of picking the right answer. Should we move forward?
Let's do it.
Okay. Maybe we can do a couple more questions. I'll let Sana answer another question, and then we can decide if we want to go straight to the Q&A.
Sure, sounds good.
Awesome.
So I think this is another one of Brad's.
Oh, is it?
Yes.
All right. Let's see this one.
Perfect.
Is this one of yours, Sana? Okay.
Yes, it is. Thank you. All right, so here we have, and like I said, I like to dive right in. So 48-year-old woman presents with for evaluation of abdominal pain and fever. Okay, so right off the bat, 48-year-old lady, demographics are always important. No matter what it is, it's always relevant. 48-year-old woman, abdominal pain and fever. So at this point, my differential is still super broad, so I'm just going to keep going. Her pain began 3 days prior and is described as sharp pain in her right flank that has now radiated to her groin. So that sentence alone, just hearing that, I'm sure a lot of you are screaming that you know the answer. So for those of you who are still thinking you might not know, anytime you see flank pain radiating to the groin, kidney stones, kidney stones, kidney stones. That should be the first thing that jumps into your mind. Especially the word flank in general is very specific to the kidneys. So you could, kidney pain in general, you could be thinking about pyelo, but the radiation is very specific for the stones. So now I'm thinking about kidney stones in general. So 2 weeks prior, she experienced dysuria, an increased frequency of urination. So sort of thinking, okay, I know she has kidney stones. I'm thinking along the GU tract, right? Kidneys, ureters, bladder, urethra. So these symptoms sort of follow along with that. So it sounds like she had a UTI. Though she did not seek medical intervention at the time. Okay, so an untreated UTI. So when I go through these questions, I try and take the information as it comes and then step back and pause and try and continue to diagnose as I'm moving along. Sometimes your differential will change, sometimes things will narrow or broaden, sometimes you won't know until the very end. But if I can have information to support my theory as I move forward, I feel more and more confident in my answers. So now I'm thinking, okay, kidney stone, she had a UTI, complicated UTI, or not complicated because that has different connotations, but she didn't take any medical treatment for that, not treated with antibiotics. Denies nausea, vomiting, diarrhea, okay. Medical history is remarkable for hypertension. She currently takes lisinopril. Okay, sure. Lisinopril I know is an ACE inhibitor, so has some effects on the kidneys, so worth keeping that in mind for now, tucking that away. She is sexually active with her husband and has no history of sexually transmitted infections. Okay, so that's something else you should be thinking about whenever you think of any urinary symptoms. It's also possible, especially in females, that UTIs are often caused by sexual intercourse, but also any sort of STIs can sometimes get confusing in terms of their presentation. So sometimes vaginal symptoms get conflated with urinary symptoms, so good to keep in mind, but no history of STIs in this patient. Temperature is 98.7, fine. Pulse is 80, fine. Respiration 16, fine. Blood pressure 130/85, fine. So like Fred was saying, you should always have an idea of what normal vitals are, just because those are going to be given to you on almost every presentation. So you want to just be able to knock through those and not have to open the tab every single time. Patient is uncomfortable and unable to sit on the exam table. Okay, I know she's in pain. She's having some fever, even though right now her temperature seems to be okay. Tenderness to palpation in the right lower quadrant. So right flank pain, radiating down to the groin. Now she's having right lower quadrant pain. Denies CVA tenderness. Okay, so CVA tenderness would have sort of helped me a little bit with the diagnosis, but again, just because one thing's pointing you in the other direction does not mean it looks like a duck, quacks like a duck, right? This is definitely still kidney stone. So then they give us a urinalysis findings, right? So we know she has a UTI, very likely. So now they give us a urinalysis to sort of help us figure out what type of UTI. So Luke esterase is positive, confirming UTI. Nitrite's positive, confirming UTI. Bacteria, definitely confirming UTI. So all of these things are sort of supporting what I already think. White blood cells, high, supporting UTI. Red blood cells, high. So red blood cells, this does not necessarily support the UTI idea, but anytime you see red blood cells in the urine, there are a couple things you should be thinking about. One of them is always kidney stones. So we know she has a kidney stone, right? So I can explain that away. If she just had a UTI and red blood cells, that might be a little bit more concerning to me, but I know she has a kidney stone. So that explains that finding in the urinalysis. And then most importantly in this stem, urine pH is 9. So urine, as many people will see, as you can see in the labs tab, is typically acidic, right? So pH of 9, 0 to 14, right? 14 is the most basic. 9 is a very, very basic pH. So we have a high pH. So that's suggesting to us a couple of things. So we know she had a UTI, and we know she has a kidney stone. And so those things have to, for some reason, be related together. And in the setting of a high urine pH, that's making me think about struvite stones. And struvite stones are, we'll talk a little bit more about this when we get into the answer choices, but struvite stones are most commonly associated with UTIs from certain organisms. And once we talk about those organisms, we'll get a better sense of, you know, just making sure we have those associations drilled into our heads. So now we have all of that sort of confirming our diagnosis. Abdominal ultrasound shows right-sided hydronephrosis and dilation of the proximal ureter. That makes sense, probably has a stone, everything's backed up, right? Which of the following is the most likely underlying cause of this patient's symptoms? So again, basically they're asking you what's the diagnosis here. So we know she has a stone, and we know that the stone, we know she had a UTI, and the UTI sort of precipitated by these organisms leading to a stone. So the question is, what type of stone does she have, and what type of bugs are we dealing with? So we'll just go through option by option and think about the different types of stones and the different types of UTIs. So the first option is increased renal excretion of calcium. So that makes you think of the most common stones, which you can have in kidney stones, which is calcium oxalate, right? That is the number one type. You can see calcium oxalate, calcium phosphate, and calcium oxalate is number one. And that is most commonly associated with just day-to-day patients, right? A normal person who gets a kidney stone, no diseases. You can also see it in people who have, I think, increased vitamin C intake, people with Crohn's disease. There are certain risk factors that you associate with having a calcium oxalate stone, but calcium oxalate stones, no association with high pH. There's no real association there. And beyond that, calcium oxalate stones normally don't come with UTIs. They just happen by themselves. So less likely for that diagnosis. Infection with E. coli. So E. coli is the number one cause of UTIs, right? It is the most common bug that will give you a UTI, but to my knowledge, no association with stones whatsoever. E. coli doesn't do anything that sort of predisposes you to getting stones, and it's, again, in more acidic pHs. So I'm sort of drawing on what is my knowledge of UTIs and what is my knowledge of stones for these questions. You sort of have to toggle back and forth because the option choices sort of toggle back and forth. And then option C, infection with urea splitting bacteria, right? So urea splitting bacteria. So that means these bacteria are urease positive. And the classic bugs that we think about for this, Klebsiella, Proteus. Those are the first ones that should jump into your head. And what's important is urea splitting produces ammonia, right? That is what urea splitting bacteria do, and that is what drives up pH. So these bugs drive up the pH in the urine, which is supported by what we have here. And we know, because of the associations with these specific bugs, they are associated with with struvite stones. So Klebsiella, Proteus, high pH, struvite stones. So this is the only UTI that I know of that's associated with a stone as well, and it happens in urease producing bugs, and it happens in a high pH, all of which is supported by this patient. So far, I think this is a slam dunk. If I was feeling particularly confident, I might just press this and not even keep looking. But because we're being thorough, we're going to keep going through the other options. Option D, uric acid production, right? So that's another type of stone. So increased uric acid in the body will lead to uric acid deposition in the kidneys, and you can lead to uric acid stones. This patient has no reason to have high uric acid production, right? So uric acid production, you typically see people who have gout, right? These are the people who drop uric acid and into their joints, and that's why they get the inflammation and the pain. Or in cancer patients, right? Because you're having rapid turnover of cells, and the rapid turnover of cells leads to increased uric acid being produced in the body and therefore being filtered through the kidneys. But again, no associations with UTIs whatsoever, and so I have no reason to suspect that. And then finally, decreased reabsorption of amino acids in the proximal convoluted tubule. So this is where they're talking about the COLA syndrome, I think is what it's called. And so that's the cysteine reabsorption, and so then you get the cysteine stones. And so but this is, again, like we said here, a reabsorption of amino acids. This is a genetic disorder, right? This is something that people are born with. So this patient, much older, 48-year-old woman, And so this would present in a child, a much younger patient. And again, no association that I know of with UTIs. So the only thing that fits, urea splitting bacteria, Klebsiella, Proteus, struvite stones, it's got to be C. All right. So big things here is really knowing both the sort of different things about stones, so knowing the different types of stones, knowing the risk factors for those stones, and knowing sort of what type of findings you have. So one of those findings being what is on the pH. Is it an acidic urine? Is it a basic urine? And that will help you sort of stratify into what's more likely. And then another thing that was not brought up on this question is sometimes imaging. So knowing what shows up on CT, what stones don't show up on CT, and same goes for X-ray. Those are things that could be tested in questions as well. And then also knowing about UTIs, knowing a little bit about the association with stones, but also what bugs can cause them and what to be looking for in the urine.
Awesome.
All right, awesome.
Terrific, excellent rationale. A lot of this stuff does come down to just kind of sheer memorization of the associations of symptoms and syndromes and then lab findings and things like that. This is, I think, where the hard part of studying for STEP comes in, because it can be kind of exhausting and a little bit boring. But I thought you handled that really awesome.
Thanks.
All of this stuff is quite high yield for the STEP as well. There are tables in first aid that kind of talk about these things over and over again. It is to your advantage to know these things inside and out as you approach questions and move through your training. Sherry, do you have anything to add?
No, nothing to add.
Awesome. We are gonna switch gears a little bit here and move very shortly into the Q&A. I'm gonna bring my screen back here. And after a little pause. Okay, I think we're back. Does that work?
Yes, got it.
Excellent. So maybe for the next 5 minutes or 10 minutes, Sherry, you can tell us a little bit more about TrueLearn. We'll talk a little bit about MST, and then we'll jump right into the Q&A.
Yeah, I'll take no more than 5 minutes. I mean, we are TrueLearn. We've been around for quite some time. We started the company in 2003, and we started actually creating a question bank for osteopathic students. And so that's kind of what we're known for. What the name that you may hear is ComBank. Shortly after that, in 2008, we had a big need and a big want from a lot of students to say, and faculty say, what about a USMLE bank? We have a lot of osteopathic students that want to take USMLE Step 1 and Step 2. And so we kind of dived into that market and have excelled. And we kind of rebranded because ComBank is associated with ComLex, which is kind of your osteopathic equivalent to STEP, and rebranded to our bigger company name of TrueLearn. So TrueLearn is our umbrella term that houses question banks for ComLex, for USMLE, and then we also dive into the residency market as well. So Fred, if you go to the next slide. A lot of you guys don't know that we have trained hundreds and hundreds of thousands of physicians. We work with not just students individually, but we work with 40 plus allopathic and osteopathic schools with your faculty, with your administration, with your dean, and then very closely with the students as well. Myself, Dr. Corney, who is the founder and CEO, who is also a board-certified anesthesiologist. He goes around the country and he gives talks, and so you may have heard him before. We work with over 600 residency programs. And so if you, as you transition from your first, second, third, fourth year of medical school, you may find us again when you go into residency. So we're super excited. Some of the schools that we work with may be one of yours now or in the future. Let's go to the next slide. What sets us apart is we are popularly known as a question bank, as a Q bank, right? But we actually brand ourselves as a smart bank. And this is because we actually take your data that comes in, and we try to personalize that learning experience for you. So we're not going to just show you numbers, percentiles, conversions, and that kind of stuff, but we actually want you to be a better test taker, a better learner. Okay, and so we're taking your data, and we may include cards. So if you saw on the dashboard, you may have seen a little purple card that said growth mindset. And so as you're taking questions in the bank, our system may notice that maybe you're doing a lot of guessing, you know, and that may be a sign of just not being very confident with your answers, or maybe you're switching from right answer to wrong answer to right answer to wrong answer. And so you may get a card that will display something about growth mindset. We like to, you know, dive into the learning science. And so if you've ever heard someone say, go with your gut, you know, contrary to that belief, it's not always the best approach. And so if we're finding that you're, you know, 75% of the time you're answering the right answer, and then after some time you choose the wrong answer, you may get a card that says 75% of the time you've switched from right to wrong. And then it'll give you an article to read about how you can improve your test study strategy. If you go to the next slide, another thing that we do is you saw those bottom lines on those each of the items has a bottom line, which is a takeaway point. We take advantage of spatial repetition, which is another learning term, and that is the idea of you know, re-exposure to different concepts that you don't know after a period of time. So usually it's about 3 days, and you relearn that concept, and that actually solidifies long-term learning. And that's why testing effect is so impactful, is that every time you're testing, you're kind of re-engaging your brain to switch and to learn and to really memorize. So it's not this rote memorization that you're sitting down and just going over you know, concepts. And so we actually text you if you sign up for the notifications, and you can customize when you get these text messages. If you miss a question, we will text you that bottom line. 3 days later, you can go back into the bank and review that concept. But 3 days later, you may have forgotten it. So this is kind of jogging your memory and reinforcing that learning. And so lots of exciting things that are happening in our bank for step 1 and beyond, and then also in our residency markets. And so if you're using our bank now or later, there's going to be a lot of improvement. We're using a lot of AI and machine learning and so forth. For our USMLE Step 1 bank, we have over 2,000 questions, and this continues to grow. We are constantly revising and pulling questions and putting questions in, and so you're going to have at least 2,200 questions. But that may, you know, today it may be 2201, tomorrow may be 2205, because, you know, we are looking at the questions and pulling questions and seriously reading your feedback and everything that you guys put forward. We follow the NBME blueprint, which is very, very vital. And so if you have not studied the NBME USMLE blueprint, I advise you to go and search for that and figure out, okay, what is high yield and what is low yield? What am I going to be tested on? And because they tell you exactly what concepts they're going to test on. You saw me switch between the 2 testing environments, and so we do have a USMLE skin that looks similar to what you'll encounter when you take STEP, and so that's really important. And I know it's very small, but that if we can reduce some of the anxiety when you go and sit for the exam, that helps us and that helps you. And we have multiple subscriptions options, so, you know, 30 days, 60 days, 90 days, 100, 365 days. So it's exciting. Love to talk more if you're interested. But that's all for TrueLearn.
Thank you, Sherry.
Yeah.
Fantastic. I'm gonna take maybe just a few moments just to talk a little bit about MST, and then off to the Q&A. So essentially, we are somewhat unique in how we like to prepare people for exams. We kind of come from some modest beginnings, just being in the idea of, hey, maybe we can work with students on a one-to-one level, really try to advocate for like that one-on-one ratio, and really serve as a tutor and a coach and a psychologist and a cheerleader and a mom or a dad to you as you go through this process. Sometimes you need somebody to kind of kick you in the butt a little bit to get motivated, and other times you need somebody to cheer you on, or maybe just have a shoulder to cry on. And we can sort of be all of those things to you. The way that I like to sort of go into these kinds of things with my students is that I kind of serve as the basic science consultant. So when I'm tutoring, it shouldn't necessarily be your worry as to waste all of your time trying to figure out, oh my gosh, where is this random fact somewhere that I'm supposed to link together in my head? If I can provide you a mnemonic or something easy, or maybe even a little bit of homework on my end to find a specific answer for you, I can do that. You can focus on the higher yield stuff. I can maybe put some of the pieces together so that it makes your learning a little easier. And then through that teamwork and through that partnership, we get you to the next step, and you wind up doing really well. I've tutored dozens and dozens of students in the past several years that I've been working at MST. I've loved every single experience with them, and I'm not just saying that. I find that the behind the scenes, our tutor liaison team is phenomenal at pairing the tutors with students with very similar personalities, or maybe the kind of personality that the student is asking for, because they know that they might lack a quality that might make them a great studier, and we can sort of motivate you to get into that mindset. The nice thing about at least my interaction with students is that since I've been doing this for so long, the students that I've tutored are now residents in their respective fields, and some of them are even getting to the point, like especially in medicine and pediatrics, where they're graduating and they're becoming attendings, and here I am still a resident for students. But radiology's long. But in any case, it's great because we start into this communication with you, and we get to know what your needs are. And if this isn't like a student-teacher relationship with MST, it's more of like it's like a colleague. You know, we're looking at you as if we're colleagues, because that's what we are. We are just a couple of years ahead of you in the journey that we're all sort of taking together. So at the very end of it, at the very least, you can create a really cool pen pal that sort of goes through with you, and you might see each other at conferences and things in the future. So it's not only just test prep, but it's also sort of lifelong learning. It's motivating you to do something bigger than yourself, and make new friends and colleagues along the way. And that's the kind of things that we're really dedicated to doing to help you. If you are interested in any of this that we're talking about, please, we advocate that you just call our office and talk to somebody on the other end. These people are so nice, and they're willing to give you their time for really nothing. If you were interested in signing up, there is a cool promo code for there. There's absolutely no obligation to do that. You do you. If this is something that sounds awesome, that's fantastic. If not, that's also totally cool too. There's no pressure there at all. With that, I'm going to wrap that up, and we're going to go into the real meat of this thing and get into the Q&A, because I don't want to spend any more time talking about some of the other stuff. Please write your questions in the box. We are happy to stay for as long as it takes to answer the questions. Once the questions sort of start trickling out and come in slower, we might wrap things up, but please go ahead and send them. We're going to try to pick things off, and I might field some questions to our awesome to my awesome co-hosts, and then also the people behind the scenes who can answer some more of the logistics stuff behind TrueLearn and behind MST can answer you guys privately and go from there. I'm going to leave this slide up simply just because we have the code here. You can screenshot this, you can take a picture with your phone or something if you are interested in getting in touch with us. So starting to see some excellent questions come here. I really do like this one question that I'll throw out to Sana here, and that is, how do you memorize for step one? It seems like so much of it is memorization rather than reasoning. What are your thoughts on this, having tutored so many people in it, and what do you recommend for this kind of strategy?
Yeah, absolutely. And you're totally right. I think that there is a significant proportion of step one that is just, can you remember facts? And I found in my experience with students that everyone is a little bit different. Some of my students love flashcards, and some of them love the repetition of flashcards to just drill things into your head. I will say that the students that I've had that use flashcards successfully use it for a very extended amount of time. So this is not someone who picks up the whole Anki deck a month before their exam, right? This is someone who's been working at it consistently throughout the year before the exam, really hammering those facts into their head. And I think that is a very effective way of memorizing if that's what you choose to do. I've also had students who really hate flashcards, and I was one of those people. I personally did not find flashcards particularly useful to me. I was a big fan of questions, and that was sort of my supplement that I did something different. I think that most of my students who don't use flashcards do significantly more questions, and that's through a variety of different banks. So they would do an extra hour of questions when they're their sort of colleagues would be doing flashcards, and the questions sort of drill into your head the presentations and the things that they like to test. So in a way, I think that that is almost more useful because you know specifically all the small details that they like to test. Because using the flashcards can be useful, but some of that information is sort of picked out as like what you think might be helpful or what the creator of the deck might be helpful. Versus if you're using a deck from, or if you're doing questions from trained professionals who have curated these questions, then you know every small detail that you're seeing over and over are the things that they have identified as key question points and key sort of disease points that like to be tested both in life in terms of patient presentation, but also in terms of the exam and what gets tested. So I think, and I personally find it a little more fun than flashcards, just doing more questions and repeating into your head and being able to really quickly identify things.
Awesome. I agree. I definitely think that there's a lot of memorization for this stuff because there's just so many facts that you kind of have to know. And yes, I guess the mindset that I would send students away with is to remember that step one is truly, it's not a medicine test, it's a science test. This is a test about science and your understanding of basic science, how the body works properly, and then what happens when the body breaks down a little bit. And it's asking you to remember some of the key players in physiology and pathophysiology that come in. Understanding the bigger picture, the concepts, being able to speak very fluently about how one thing sort of goes into another is going to help you sort of create the story behind something. And then from there, the details can sort of file in as you need to do it. Memorizing details is very painful. We've all sort of done it. It's a lot of trivia on this test sometimes. And a lot of the stuff, you're right, is not necessarily going to be real life medicine, because how often are you going to see cryoglobulin disease? Right? But remember, a lot of the time on step one, the questions are not there to test your ability to diagnose something super rare as cryoglobulin disease with hepatitis C. It's more to ask you, are you comprehending the thought process of how you got there? Are you understanding the pathophysiology behind something like this? And maybe a little bit of it is recognizing like a classic vignette of somebody with hep C, but now with some weird rash. Where is it coming from? You have to sometimes consider the zebras, even though they might not always be the diagnosis, but it's all a thought process test, and the details are there to sort of reinforce the theory, the overarching picture. I like this other one. I'll sort of go through this one real quick. How do you answer vague vignettes? I kind of love this question. There will be a handful of questions on every kind of standardized test you take from now until the end of time that are going to be very vague. They're going to give you very little information in the vignette, and you're going to be sort of scratching your head and thinking, well, where was this in first aid, or where was this in my Q-banks? I don't remember ever. And that's because it's not anywhere in those things. The whole point of a vague vignette is to take a minute outside of the memorization, actually test how you're thinking as a doctor for a minute. One of my favorite questions is, at least that came up in the past, was something about a telephone line repair woman and how she came in with this unusual rash across her forehead. And she was really, really stressed about it. She came to see you, the dermatologist, to do this, and it looked kind of like pustules, almost like it could be a bad acne, but you weren't really sure. She had an infection a little while ago. There was like an upper respiratory thing. She has a family history of some autoimmune problem. She does this. She eats a lot of chocolate, loves chocolate, awesome at chocolate, right? Takes some OCPs, does a couple of has some other, she occasionally smokes marijuana on the side, drinks socially with friends, lots of vague things like that. Now they're asking you, what's the most common thing? And if you read the vignette carefully, you would also realize that as a telephone repair worker, she tells you that she wears a helmet every day at work. And simply the helmet comes down over the forehead and limits the rash to that one part of the body. And it's simply just acne from trapping the sweat inside of where the helmet is on the head. So sometimes these vague questions are going to stretch your knowledge to ask you, okay, well, what are they really asking me here? Don't overthink these things. Take all the facts as they sort of come to you, align them in your head, ask yourself what's the most important thing that they're asking me here, and then see if you can come up with a reasonable solution. Again, Occam's razor, the most simple answer is generally the right one, okay? And go with that. That's how I would approach vague questions. Looking at some other questions here.
There's a couple.
Oh,
about
sorry.
time.
Go ahead.
I'm sorry, Sana. Oh, I was
No,
just
no.
there's a couple of questions about timing, and I know that time management is huge, problem, and also something that a lot of students kind of try to tackle. And it feels good to take questions in untimed and tutor mode, right? Like you're not under the gun, you're just kind of recalling information. I mean, even through this webinar, we took about 7 to 10 minutes per question, and you don't have that much time when you take steps. And so the highest performers that we have found take most of their questions in time mode. Not only does this help you kind of manage your time, and you have 92 seconds per question, you're going to go through, you know how much time you can read the vignette, and you know how much time to read out the answer choices and then process it. But it's going to kind of help you just kind of switch back from, what maybe it's an anatomy question, maybe it's a cardiovascular question, maybe it's a different diagnosis that you have to switch from. And so you need to learn and train your brain to think that quickly. And so I recommend, if you aren't taking more timed questions, to take a steady diet of questions in timed mode so that you can start practicing that. Do you guys have anything to add on that?
Yeah, I actually was just about to bring up that same point. I couldn't agree more with that. I think when you're preparing, I think if you have a long period of time before you're taking the STEP exam and you're sort of starting out in your preparation, it's okay to take things untimed. I think as you're sort of learning and beginning the process, you're going to be slow. You're not going to be used to any sort of Q-bank questions. So you should sort of go slowly in the beginning, and I think that's very appropriate. I think as you get closer to the exam, it is essential to simulate the real thing. And so once you get closer, you need to be timing yourself. As far as strategy in terms of time management on the questions, I think there are a couple of things that I've suggested to my students. One of the things I suggest is, and this sounds scary, is you have 40 questions and you have an hour to do them. Give yourself 50 minutes. It forces you to go a little bit faster. It forces you to think faster. And then when you take the real thing, you'll find you have more time than you thought you had. And so I think that's one strategy that I tell people, usually closer to the exam. Another thing that I've often suggested, and this is one that most of my students have had a lot of success with, is when you go through a bank of 40 questions, answer the ones you know right away and just skip the other ones. If you read a question and you see the answer choices and you say, I have no idea what's going on, skip it. Don't spend any time on it. That question is worth the same amount point-wise as the question that is very straightforward COPD. So you should absolutely get all of the questions. Don't save the questions 30 through 40 that could be easy, free points, because you spend 10 minutes on a question that's like number 5 in the bank. So go through, answer the ones you know right away, and don't rush, but answer the ones you can reasonably by thinking about them. But if you see anything that's totally stumping you, don't waste time. You can go back at the end. And I think that that's something that a lot of people have trouble doing in the beginning, because it's nice to sort of, sit down, do a question and move on completely instead of having it hang over your head. But I think that's just a matter of mindset, and you have to be able to sort of say, okay, I'm going to put that aside and move on to the next thing.
Awesome. Excellent answer. I'd also just like to add one quick thing at the end, and that remember that these questions, there's a lot of things that they're testing you on the exam. And the idea is that these should be answerable within maybe 60 to 70 seconds. So when you're going through these questions, if you start overthinking and it's taking you way longer to really figure out what's going on, you might be overthinking it. Take a step back, think about the big picture, and go from there. Let me see here. I like this one question that's sort of more, I guess, I don't want to say existential, but it's I guess kind of complimentary. But if I'm interpreting this question fun, it says essentially how are we able to recall this information this quickly? So one, thank you. Two, what Sana and I have done to prepare for these exams is not an easy task. And those of you who are going through a dedicated study period right now of what most schools give, somewhere between maybe like 6 to 10 weeks, depending upon where you go to school or how much time you feel like you need, 8 weeks being generally the average. In that time, it really comes down to a lot of self-discipline, a lot of long hours, early in the morning to somewhat late at night of serious study and focus. Having a plan, having a calendar, having something that you can sit down and reliably follow on a daily basis, knowing that you will hit, say, a page goal or a question goal at the end of the day to guarantee that you will get through that material is paramount. And understanding that your goal should be to get through that material more than once. And that's where that spaced repetition comes in. That's where that self-discipline, knowing, you know, I need to sit down and study endocrine as if I'm never going to study endocrine again. You know, even though you know you will hit it a second time, you want to go through that first pass really thinking to yourself, I need to know this super well, such that if I were to never look at this chapter again, I would have a really good understanding of what I would be talking about. A good knowledge of that is to be fluent with yourself in some of this subject material. Have conversations with yourself. Your friends and family are going to think you're insane, but it's true. I mean, when you're making lunch or dinner for yourself, you know, you might be going through a concept in your head, and you should be telling yourself that story with some of the details sprinkled in about how everything sort of fits together. Yeah. You can play games with yourself where, you know, you'd have a glass of water on your desk, and every time you wound up having to go up and refill your glass of water on your desk, you'd say, okay, I'm not allowed to sit down at my desk until I recite every RNA and DNA viral genome, and then I will allow myself to continue on with what I was doing that day. And sometimes it just has to come down with playing those silly memory games with yourself until they stick somehow. It's painful. It's absolutely painful, but these are the kinds of hours that this kind of exam requires. And it's cruel and it's mad, and you can be angry about it. But I have also found that the more successful students who do well on this are people who kind of embrace the torture a little bit and realize that this, right, like this process is only 8 weeks. It's only temporary. You have the rest of your life to do your dream job in whatever specialty you will achieve. And you all have the capacity to do amazingly well on this test. So why not suffer for just a little while so that you can get exactly what you need? With that mindset, it got me even further. I wrote on a flashcard, or on a 3x5 index card, if people even still know what these are these days. When I was studying for step 1, put it on my desk, and I said 250 would be rad, because radiology. So that was my goal. That was what I wanted to hit when it came time, because I figured that would be a safe enough score to get me into the residence that I wanted. And then at 254 later, it worked out really well. So it's all about what you got to do to motivate yourself to sit down, put those hours in, be honest with yourself is what you're doing, right? 10 hours of studying may not always equal 10 hours of studying, because 4 hours of that could be procrastination. Shut off social media, put your phone on Do Not Disturb, throw it in the other side of the room, tell your parents and friends, look, I gotta hibernate for like 8 weeks. Nobody's allowed to talk to me. I gotta do this thing. You are allowed to continue to do the things that will encourage you to focus. So if you go to the gym or go for a run or something, and that encourages you to sit down and get really good hours in, then continue to do those things. But you know, it really comes down to that. And the fact that Sana and I can sort of regurgitate this information and just know this comes from a little bit of review before these kinds of things. But a lot of what we were talking today was really off the fly. Like this stuff is buried in our long-term memory for some reason, and I can't seem to shake it out of there, no matter how many nights I have. But this is the product. What you're seeing with Sana and I is the product of what these hours of preparation really yield. So be honest with yourself in what you're doing. Really give this your full effort going forward, because you can get what we have. We are not that much smarter, or really, I don't think we're smarter at all than you. I think we're at the same level. Like, I am not a very smart person. I was like a B+ student in medical school. Like, it's not an unachievable goal to get to that 250+ club. Like, you can do it too. Okay, don't ever feel discouraged about that.
Yeah, I think that I echo absolutely everything that Fred just said. I think one of the big points that I'll reiterate is really, my family reminds me that I famously said, for the next 8 weeks, pretend that you don't have a daughter, pretend that you don't have a sister, I don't exist. I'm going to be in a hole, and I'm going to be studying all the time. And I think that that's what sometimes it takes. Having said that, I really, really echo what Fred was saying, in that we are not that much smarter than anybody else. I think this is attainable by absolutely everyone. If you got into medical school, you have what it takes. And I think that it's really important to remind yourself of that, because there's certainly, there's a lot of imposter syndrome in medical school, and this feeling of everyone around me is so much smarter than me and they remember things that I can't remember. But I assure you that is not the case. And really, it just comes with a lot of time and a lot of practice. And like Fred was saying, the most successful students I have found are the ones who really say, this is going to be my life for a finite amount of time, right? I'm not asking you to spend a year doing this because that's insane. But I think that anyone can do it for a short period of time. And if you can devote yourself completely to this process, and it's a lot to ask, and people have reasons why they can't, right? People have lives outside of, not everyone can take 8 weeks and just say, I'm going to be in a hole for 8 weeks. And so absolutely do what you need to do. But I think that the people who do succeed in the ways that they really hope to achieve are the ones who are able to really carve out time in their day and say, for this amount of time, however much that you're able to dedicate, really say, this is just going to be about this. I'm not going to do this and also be, doing laundry and also be, texting my friends. You have to just devote yourself to one thing at any given time.
Totally agree.
I do want to say it's very important to take breaks and very important to sleep. So
Yeah,
take time to rest and recuperate and then get back into it. But I absolutely agree. Like, it's a dedicated time. You've devoted your time. This is an investment. So invest in yourself. But yeah.
To stay organized with these kinds of things, because this is also a big question that I get as a tutor a lot, is, excuse me, how do I stay on check with things? If you just, with MST, I mean, we create calendars for you. So we will create like what you should be reading on like a day-by-day basis and how many questions you should be doing like that. But let's say you didn't want to do something with MST. There are apps and things out there that can help you organize your schedule. I think Osmosis is one of those programs that kind of works like Anki or like a spaced repetition flashcard, but also they've got resources in there that you can assign and sort of put like a start date and an end date, and it'll distribute those resources over those times. I think that's a free service. And then for a paid service, there's Cram Fighter, which I find very useful and intuitive to use. It's an app, it's also on your computer, and you can basically input those resources that you plan to use in first aid or any other textbook. With the most recent edition, it updates all the time, and it'll create a calendar for you that's exportable and everything, and you can know what you need to do on a day-to-day basis. Staying organized is really a huge key to success here. Holding yourself accountable for the material you need to cover in a day is crucial to your success in this exam. Do not let yourself slack. In these 8 weeks, you cannot let yourself slack. Even for that reason, I don't necessarily allow my students to schedule like recovery days or days off, because at the end of 8 weeks, that's a week and a day of not studying out of 8 weeks. It's not a lot of time. That's all. That now you've only studied for 7 weeks when you had 8. So again, the temporality of this is incredibly short and succinct. Do yourself a favor and really put your best foot forward to this. Stay organized. Go for it. If you need a break from the madness, take a half a day after you've done something productive that day, or after, say, an NBME exam where you crushed it. Maybe you've earned the second half of that day off after you've like reviewed your answers and stuff like that. Maybe no new material that day, but for the most part, really try to stick to something through and through. Let me see what other kinds of questions are here. Let's see. So a little bit of test day strategy. This is always a good question to address. You're going to get there. You're going to be a little kind of scared and nervous on the actual exam day, and it might be a little different than what you've experienced during practice exams. Adrenaline is your friend in this case. You're not necessarily going to like fall asleep in the middle of your test because you're going to be nervous. It's okay. Everybody is. How I would recommend it is that you've got essentially 7 blocks over the course of 8 hours, and one of those hours can be for is essentially your break. So you can take lunch during it, you can go and use it sort of as you'd like to break it up, go to the bathroom, to have a snack, whatever. Day of, if you are a coffee person and you drink coffee every single day of your preparation for this exam, test day is not the day that you stop drinking coffee, right? That's the day after if you have a New Year's resolution or something. But you definitely want to keep those habits that you've done while studying for those long marathon sessions going during the exam. Adrenaline's your friend. It's going to give you that extra boost. It's going to send adrenaline to your brain, and your brain's going to be on fire that day. You're going to be good. You're going to go in. Don't let the anxiety jump on top of you and cripple you. Use your instinct, use your gut to answer things you aren't quite sure about, but also use that logic that you've done with all that repetition to get you through. When it comes to breaking on test day, my personal method was, it worked for me, it may not work for everybody, and I would leave that to your discretion. Because I was so jacked up on the adrenaline of the day, I took the first 2 blocks kind of back to back, where I did block number 1, I took maybe 15 seconds to just kind of stretch my upper body and my arms like this at my desk. And then I jumped right into block number 2 after that. In between block 2 and block 3, I took maybe a 5-minute break to stand up, go to the bathroom, walk around, do push-ups in the hallway because I'm crazy like that. Then I went back and I did block 3 and block 4 the exact same way I did block 1 and block 2. I took a 15-second break in between 3 and 4 just to stretch out a little bit, you know, crack my knuckles, stuff like that, and then I jumped right into it. At that point, I was more than halfway done with the test, and it was awesome. So I said, you know what? You've earned a 20-minute lunch. Don't eat a crazy amount to throw you into a food coma. Not a good idea. Eat just enough to keep your brain on, and then right back into it. Knowing that I had plenty of time with the breaks, with only 3 more blocks left, I forced myself to take a 5-minute break after block number 5 and block number 6, just to spread it out, to make sure I wasn't getting tired. I jogged a little bit, I got my heart rate up a little bit, I got myself psyched again, because that adrenaline will fade. You get into sort of that comfortable area after a while, so you gotta keep that blood flowing. So do what you have to do after that. After block 5, 5-minute break. After block 6, 5-minute break. After block 7, exam's done. You're finished, okay? It goes way faster than you think, okay? So use those as a guide. If you like that idea, please totally use it. It's not copyrighted or anything. Other people like to take a break after every section. Just keep an eye on your break time when you're going through it.
Yeah, absolutely. One thing that I did, so I was extremely nervous on the day of my test. And so I took the first section, and I could sort of feel myself through that section, like freaking out as I was answering all the questions. I could sort of feel the anxiety like leaching out onto the questions and onto my performance. And so I think it's really important to be cognizant of your own sort of mental state and just know where you're at, know how you're feeling. So what I did was right after the first block, I was very pumped up on energy, but I think at that point for me, it was a little bit of negative energy. So I took 5 minutes after the first block and I was like, I need to just calm down. I went to the bathroom, splashed some water on my face, definitely wasn't doing push-ups. But I think I just needed to take that moment to sort of calm myself down and orient myself to where I was and go in and be my best self in that exam. So you will know yourself best, and so really sort of feel out what's working for you and if you think you're doing a good job. So I did that, and then really for me, the food, I tried to do snacks throughout the day. I didn't have one like lunch. I sort of had a couple things after the first 2 blocks, a couple things after the, like grapes, crackers, just random things throughout the day. That way it avoided the food coma, but also I just like kept myself sort of energized and feeling upbeat throughout the day. And then the one thing that I will really recommend is go to the bathroom before you feel like you have to go to the bathroom, because the worst thing would be sitting in the middle of a block and really feeling like you need to pee and having to get through another 30 questions before you are able to go to the bathroom. So just go preemptively, don't worry about it, and then you will save yourself a lot of trouble.
I like this. Back to some question strategy. So how do you approach questions that have too much information? Again, these are going to be on the exam, especially in step 2. You might see more of that when you get to step 2 and step 3, because the vignettes are going to be longer. You know, there's a lot of facts in there. Again, remember that most of the things, if not everything in the vignette, is going to help you arrive at the right answer. I tend to, when I see big questions, I use my strategy, go to the end of the thing first, ask yourself, what is the objective of this question? What is the question actually trying to ask me? And you might be surprised that the question is actually like very not related to the entirety of the vignette that you're going to spend all this time reading. So maybe jump to the question first, get the idea of what you need to be looking for, and then go back and read it as you would and put it all together. Remember that these questions on this exam are designed to be answered in 60 to 70 seconds. So no matter how long the vignette is, it's probably a bunch of fluff that you don't need. And if you've studied the right way and you've understood what you need to understand, you're going to be able to weed out the other stuff and then keep all the main stuff together. You're going to realize that these questions probably tend to be easier than hard. Right. When it comes to taking practice tests, how often would you recommend taking them? Sana, do you want to answer this one?
Yeah, sure. So I am a big believer in the more practice tests, the better, depending on how much time you have for your dedicated. So if you have a solid 2 months, what I often recommend to my students, and what many of them say seems to work for them, is once every week to week and a half, they would take a practice test. And that would usually be either the NDMEs or the UWorld ones, but there are a number of resources available. And so I would say every week to week and a half if you have an extended amount of time. And I try to tell them to take as many as you're able to in that time period that lines up with the timing. But I don't think there's any number. I think it's important to at least do one. I think it's better to do 2. And I think you sort of see diminishing returns after about 4. So it's really up to you, but I do think that there's a significant benefit in terms of the timing. I'd say week to week and a half. In terms of how many you can get done, that'll depend on your dedicated study period. But I think what's really important to be aware of, and again, step 1 is so personalized, and your study period should be very personalized, so it's hard to make a blanket statement, but I'll say try to be really aware of if you're spending a lot of time assessing or if you're spending a lot of time learning. Because I think it's really easy to get into the trap of, okay, I want to see where I'm at. I want to predict where I am, and not spend that time actually making the delta and putting in the work to see bring yourself higher up. And so it's really try to be mindful of what you're spending your time doing, because a lot of people fall into that trap of, oh, I'm just going to take another practice test because I want to see if I've improved after 2 days of studying. You probably haven't. So just spend a little bit more time going through the content, really digging into first aid, and making sure that you're actually broadening your knowledge base as well.
Definitely. What are some other good questions here? So some questions regarding test prep materials and what we recommend to study for the exam and things like that, like things that we've studied. This is a very personal decision. There are lots of resources out there. I always tell my students that there is no there's no resource that is like crazy better than anything else out there, because the exam has been around for years and years and years, and everybody has dissected this exam inside and out, from top to bottom. So all the resources essentially will tell you all the same stuff. That said, when you think about the hierarchy of resources and stuff, the first resource for this test was really first aid. And to me, that is really sort of like the syllabus of step 1. I use the word syllabus and not textbook, because a syllabus is designed to show you a list of all the things that's going to be on the exam. Just like in college, when you got a syllabus for a course, you're going to go and you're going to sort of review that. And it's not going to give you all the information, all the details. It's not all the notes for the course, but it's a list of all the major things you need to know with some high yield points that are going to help you put it together. It's going to guide your studying as you go along. The nice thing about first aid is that it's a little bit more than a syllabus, and that it does have some really good information in it, so it's recommended. Your textbook, on the other hand, is going to be your question bank. I would argue that all the question banks out there are pretty good. All of them use skins that resemble the interface for USMLE, so you can't really go wrong with something like that. All of the material is all very good. It's all checked out by experts. It's how it's gone, it's always reviewed. It's always kept up to date. No matter what QBank you go with, it's important that you stick to it, and you want to finish something like that and use it to its fullest potential. you know, the areas where people sort of falter are going to be when they're using too many Q banks at one time. You're not going to be able to get through something more than once, or you're not going to be able to get through something once for that matter, which is never a good idea. My attitude is minimalism is going to be your best friend here. Limit your resources, less is more, and get through it. Go for depth, not for breadth in this situation. You're going to get the most return out of it. Now, if you needed something more supplemental, and sometimes this is necessary. So if you are, say, in your final semester of medical school and or basic sciences, and you're looking to get ready for your dedicated study period, and you want to get better at some stuff, I would say a pathology resource for review is going to be important. I like either, okay, and emphasis on the either, Golion or Pathoma, either one. You do not need both. It's the same thing, okay? And I liked BRS physiology. I think knowing a really solid foundation in physiology and pathology is going to be more than 70% of the questions on this test. So if you go into it with a solid understanding of those two disciplines, you're going to rock this thing 75 to 80%. All the extra stuff comes from various anatomy and embryology questions, which again are touched in your Q banks, and they're going to be touched in first aid, and you're going to have reviews of those things. But the majority of this test is going to be path and physio. The BRS physio book is short. It's tremendous. It's got all the relevant stuff in it. So if you give that a good read through, it's very important. When you begin your dedicated study period, you take Pathoma or Golion, whichever one you decided to use, and your BRS physio, and you put them up on your bookshelf and you leave them there. Because at that point, you want to reserve that dedicated time for your Q bank and for your first aid. If you get to a topic that you're like, wow, I totally forgot how gas exchange happens in the lungs. I am terrible at this. That's when you take Costanzo off the shelf and you're like, okay, I got to read this one section again, really make sure I understand it, and now it's going back on the bookshelf and I'm not opening it again unless I'm terrible at something. That's when that comes. I forgot what hyperthyroidism is, and first aid isn't quite doing it for me, and I'm getting all these questions wrong. That's when Golion or Pathoma comes off the shelf again, and you read about it, and then you put it back on the shelf, and that's it. Okay, just to couple that with some things, other questions regarding Anki cards and maybe taking step 1 notes in a notebook or an Excel sheet or something like that. It is not your job to write a step textbook, okay? Do not waste your time writing everything down, because realistically, are you going to go through all that stuff again? No, it's already written down for you in a super succinct method. It might be more worth your time to cover up that page in first aid and say, okay, I'm going to recite all the differentials and the pathophysiologies of thyroid diseases, and really do it and say, okay, did I miss anything on this first aid page? I did not. Yeah. Great, I know it. I don't need to write anything down for that. Moving on. Step 1 notes. If you come across a question in a Q bank that really sets your light bulb off, it turns the light bulb on, you are ready to go, you're like, oh my gosh, I totally understand this way better than I ever have, that might be worth writing down in first aid somewhere to remind yourself how you thought about something. Other than that, I wouldn't go crazy.
Totally agree with all of that. I think the big thing is really, like Fred was saying, really figuring out as you go through what your strengths and weaknesses are. And one thing I've seen in a lot of my students is it's very tempting to focus on the things that you're already good at because it feels good. But to really, if you are really struggling with embryology, as many students do, really taking a day and saying, all right, I just have to sit down, I have to get through this, I have to make sure I know every single thing. Another thing is anatomy, right? Brachial plexus, making sure you know every single detail, because once you sit down and spend a day on it, I promise you it'll get much better. So really identifying your weaknesses and taking the time to just focus on them.
For sure. Another question strategy question. I noticed that you guys don't read the answer choices after the interrogatory or last sentence question before reading the full question. Are there specific types of questions you recommend reading the answer choices before reading the question? Good observation. I would advise not to do this. The reason being is because you don't want to bias yourself with an answer choice before you go into the vignette. Sometimes we like to gravitate toward answer choices because we think we know what the question is going to get to, and then we try to make these improper connections in our mind. When you prepare for this exam, I'll repeat sort of what we said in the beginning, is that preparing for this exam as if it were a recall test, like a fill-in-the-blank type of thing, or an essay test, is going to be far more beneficial for you than preparing for it as if it's a multiple choice test. Practicing for recall is way harder on the brain. It's way more, it stresses those neurons to really kind of pull information from the long-term memory to the forefront. And it requires a really solid, comprehensive understanding of the concepts, but also the details of everything you might encounter. If you just stick with something like relying on multiple choice answers to help you get somewhere, you might encounter a question on the exam where you're going to say, uh-oh, something's not lining up, and I don't have the ability to think in sort of a global way to bring these answer choices into the forefront of my mind. So study, as TrueLearn was saying, right? Study smarter, not harder, right? You want to prepare for this exam as if you are going to be preparing for like an oral board exam, right? In front of some examiner who's going to be like, okay, what would you do in this situation? Here's a patient with A, B, C, and D. They've got this on physical exam. Here are their vital signs. This is what their chest x-ray shows. What's the diagnosis? And you might not have answer choices. You might just have to say like, well, this is what I would consider in my differential, and this is what my favorite would be. And that's how you want to prepare for this exam, is if somebody were asking you these questions in real time. Don't rely on that safety net of having the answer choices there. It's a pitfall, and it can get your mind being a little bit more comfortable than you might find later on.
Awesome.
Let me see. And for the people who are answering questions in the background, thank you for doing that. If they are still on your list, go ahead and delete those questions as they come through, or click the unclick the show answered question box in the upper right hand corner of our screen. This way we can sort of clear the ones that we haven't necessarily seen yet. Let's see. Sana, are you seeing anything on your end that you'd like to tackle?
No, I think a lot of this stuff is stuff that we've sort of been covering as we go along. I think the big things, big takeaways for really studying for this exam, I think it's important to, spend as much time as you're able to really devote yourself to this process. But I think beyond that, really to keep it in perspective, it's really easy second year or whenever you take the exam to sort of put a lot of import onto it. And I think what's really important to take away at the end of the day, and what I reflect on now as an intern, is step one is a means to an end, right? You want to get the score you need to open the doors you want to open. At the end of the day, the difference between 5 points here and there is not going to make a huge discrepancy. It's not hugely different. But what's really important is that you open the doors you need to, and to let the other stuff sort of fade back, because there's a lot of stress around this exam. So make sure you do the best you can, put in your full effort, but also try not to, lose your mind over it.
Good answer. Let me just sending some other answers here.
No problem.
Let me see here. A question for Sherry, who might be able to answer it better if it wasn't answered behind the scenes, but can you make a single quiz that has both SmartBank and USMLE questions in TrueLearn? Are you able to sort of combine those?
I answered it directly to Dr. Lyon, and actually we have two separate smart banks, and so there's a dedicated USMLE bank and there's a dedicated COMLEX bank, and they don't intertwine because the way a question is written for COMLEX and USMLE differ, and so we've addressed this already. But ideally, they're two separate banks, so it's at least 2,000 questions in one bank and at least 2,000 questions in another bank. So if there are students who are studying for both, they could use potentially two banks, which is over 4,000 questions, to take the exam, and that's what we recommend.
Awesome. Just, I guess to wrap up here, I'm going to go to you guys and say, Sana, do you have any final thoughts for our students preparing to take this exam? What would your wrap-up thoughts be?
Sure. I think the big thing is sort of what I was alluding to before, in just, you know, really focus on identifying your strengths, identifying your weaknesses, and sort of zone in on those. And this is a very long and stressful process, and understand that you will devote a lot of time to studying. But certainly this is not anything that you cannot handle, and that, again, as I sort of already said, if you got into med school, you can do well on this exam. I have no doubt that everyone is capable of doing well. It is not a difficult exam in terms of the difficulty of the questions. It's really more of a quantity thing than I think the actual complexity of the questions. It's really just a matter of the volume of material. And I think if you spend the time, if you really devote yourself, it is absolutely possible to do well.
Awesome. And Sherry, what kind of advice would you have going forward for the students?
I'll just end with, the same: study smarter, not harder. I mean, all these tips that we're giving you guys, the advice that we're giving you guys, and everything that you've read and listened to peers, utilize them and personalize your own study pattern to study smarter. It's going to be difficult. There's going to be times that you're doubting yourself, but you can do it. We believe in you. That's why we're here. We're dedicating time because we know that you guys can do it, and you need to kind of start believing that yourself. So that's what I'll end with.
Awesome. And I guess I'll just say that, to reiterate, the students who really rock this test, the secret to this, okay, the ultimate secret is, if you are motivated to do well and you work hard, you will do well on the exam. But when I say work hard, I mean honestly work hard. Check yourself. If you are sitting at a desk but not really giving it your all, you're not going to do well on this test. You know what you need to do, and you need to be honest with yourself of what you need to do. Hold yourself accountable for your deficiencies. Punish yourself a little bit if you don't know something. Make yourself know something. Go hard for this. It's 8 weeks. We can survive it. We've done it. So many people have done it, and so many people have aced it. You all have the potential. Own it. With that, we're going to say good night. Thank you so much, all of you, for joining us. Please fill out the webinar survey. It's been circling around. And really, good luck to you all. This is a really great time to be a medical student. You're going to go into this exam, and it's going to be an awesome experience. This is going to open so many doors for you. Really take the opportunity to learn all the trivia and the fun stuff. It'll help you on Jeopardy one day at the very least. And, aside from getting into residency, of course. And we all have faith in all of you. Again, it doesn't require somebody to be a super genius to kill this exam. It just requires a lot of hard and honest work, and you will have the potential. So good luck to you all, and have a wonderful night.